Welcome, everybody. Thank you for joining us today for our webinar on visualizing patient access for improved outcomes. My name is Scott Everett. I'm the Vice President of Healthcare Solutions with Practical Data Solutions, and I'm joined today by our National Sales Manager, Nick Rodriguez. So welcome, Nick.
Hey, thanks, Scott, and thanks for having me on today.
Yeah, so today, what we want to talk about are visualizations, or talk about visualizing patient access. And really what we mean is the technology that's available today in a lot of different tools allows us to really get kind of a complete picture like this and gives us some interactability to be able to look at key patient access metrics and really be able to understand where we stand in certain places and be able to take steps in order to really improve what we're trying to do.
Yeah, and Scott, before we dive into patient access, I think it's important that we take a second and talk about what it means and why it's important to visualize data, right? So visualizing data is the ability to communicate data points through pictures and being able to monitor changes and trends that exist within your organization. So oftentimes by visualizing data, we're able to see trends that might not have been, as obvious if we were just looking at, spreadsheets or, individual data points. And, we find this especially to be true when we look at visualizations that incorporate multiple different data sets that, typically aren't blended together, which, we'll talk about and share a few examples of throughout today's presentation. And there are a lot of great visualization software tools and applications out in the market today. Some of the more common ones used and that we see often are Tableau, Microsoft Power BI, MicroStrategy, and even Qlik as well. So now that we know a little bit more about what visualizations are and some of the common tools used, why don't we dig into patient access and talk about how we tailor that to this topic today.
Yeah, patient access is actually right now a very hot topic within the industry. It's something that a lot of people are looking at from a competitive standpoint, but also from a reimbursement standpoint. And really what we want to look at is if we're really trying to make things patient-centric, if we really want to improve outcomes, and we really want to think of them first, we have to understand that patient access is usually the first impression that they're given of the practice as a whole. And even if we give great quality care, even if they have positive outcomes, if they have a poor experience with patient access, they have to wait too long, they have bad interaction with the staff, things like that, it may blemish even great care that we're providing that way. So
yeah, and Scott, it's kind of funny, that reminds me of a quote I recently heard. I think it was something to the effect of, I think performing the surgery is easier than scheduling the surgeon. Now I'm trying to remember where I heard that. Can you remind me, Scott?
Yeah, that was my mom.
Okay.
I think all of us probably have some stories of, funny things or frustrating things that have happened in trying to get in to see our providers. I know that, I could come up with a lot of different stories that are out there, but really what we need to do is we really need to understand the landscape of healthcare today and realize what a huge competitive issue this is. A recent survey was done that said, when you're trying to select where you're going to get your care, the loyalty to provider is just a little over half. About 47% say they're not even concerned with who the provider is. They want to be able to get in quickly and they want the cost to be manageable. And really, when we think about it, retail outlets are giving more options than ever. If they can't get in quickly to see one of our providers, they're more than happy to go to a Walmart or a Walgreens or get what they need that way. And so it's really incumbent upon us to get people in as quickly as possible.
Yeah, absolutely. And to that end, Scott, in my role, I've had the pleasure of speaking with countless organizations over the years. And, when we talk about patient access, I'm commonly hearing a lot of the same things, right? So, one of the biggest is our patients complain about how long it takes to be seen. Or we're having challenges with referring physicians asking us to force in patients right away where we might not actually have any available capacity. So as a result of all these challenges, oftentimes our patient satisfaction scores around patient access are often getting negatively impacted as well. So
yeah, and really, again, getting people in quickly isn't just a satisfaction issue. It can be a quality issue. We want to make sure we get people in so that we can treat whatever conditions they're working on as quickly as possible. And really, when we're talking about getting people in more quickly, it's an issue of finding capacity. Now, the interesting thing about finding capacity, because I hear this all the time as well when we're working with people with patient access issues, they said, we just don't have any additional capacity. We can't find it, and we need to staff up, we need to ramp up. And a lot of times that's not necessarily the case. Finding capacity is really just looking at what are the things that we're doing from a people, process, technology standpoint that are making us really inefficient. A lot of times, if we can optimize what we're doing from a system standpoint, optimize what we're doing from a provider standpoint, we can find capacity that's out there. And I know, like, a lot of times the first place that I like to look is just digging into session volumes. So like I see here, this is easy data usually to get to, where I can see day of the week, time of the day. And right now, I know there's capacity. You know how I know? Because I look at Monday mornings and I see how much higher it is than everything else. Okay, why is it that we're not doing that every time? Now, that may be an R end, that may be a patient end, but we need to figure out why, because all of that black you're seeing right there, that's capacity. We know we can do that level because we're doing it. So why are we not filling the rest of that capacity that's sitting out there?
Yeah, great points. And, I think we can even take it a little further. So, what if instead of looking at day of the week, for example, we look at hours and, the types of appointment availability and see how that correlates with our demand?
Yeah, and looking at something like this can really be helpful, not even so much from the hour standpoint, but looking at the allocation of the appointment types that we have out there. What are we doing, freezing and holding appointments? Sometimes we do that artificially to create better access, but it's not getting done the right way. Or we start looking at, what's available from, different restrictions on visit types that can happen during certain hours that may not get filled with those specific visit types, so they just go unfilled. So we have to really understand, are there ways that we can get more efficient about what we're doing that way? And I know a lot of times when I work with a client on patient access, what are the things that you really have to have? What are the most important things? And as I started breaking things down to say, here's what I would want to know right away, here's what I would want to get to a little bit further down the road, it was interesting because I found, some key metrics, and the ones that were most important to me, luckily enough, are the ones that are usually the easiest to get. They can get really complex to get to. But the ones that you see here are usually fairly available in most scheduling systems. So if we look at a visualization on this, we can kind of see how that works together.
Yeah. So, in this visualization, we can look at it from like an individual physician level with a lot of the key metrics you just shared, Scott. But, we can also, filter by department, location, or, down to an individual provider, like I mentioned. So this is really going to help us, start to get an overall picture of, what's going on within the clinic. So we can look at things like, appointment lag times, even trends in bumped appointments, and also, trends in canceled and no-show appointments if we want to look at that too. So,
right. And some of the things that I want to look at right away is, we see that day of the week analysis that we touched on before. You can see a lot of available capacity and try to understand and compare that with our appointment lag categories, where we try to look and see, on average, how quickly can we get people in? We can see there's a lot that's in that 4 to 14 day range, and trying to understand that. Now, we may want to break that down by visit type. We may want to just look at new and return patient visits or new patient visits, because we know those are the ones that, we really have to work on getting in as quickly as possible. And you can see when we filter on that, most of our new patient visits are in that 22 to 30 day range. And that's just something that's going to keep us from getting more new patients if we can't improve that. We can look at things like canceled no-show appointments. We can look at bumped appointments. And I really like to focus on bumps, because a bump is really a provider initiated cancellation. And when we look at it from that standpoint, that's capacity that we're not using in addition to being a real patient dissatisfier. So having all of this information available can really be helpful, but sometimes we may want to take this information and go to kind of another level on it as well. So some of the metrics that may be a little bit more difficult to get to but can be very useful are things like third next available, scheduling utilization, appointments booked outside of the template. These are ones that usually require a little bit of logic to get to, or the system has to create a standard report.
Yeah, so why don't we look at another example here of another visualization that has some of these more in-depth metrics, right? So, we can see things in this example like our scheduling utilization, by looking at our, booked versus available appointments. We can see our, third next available appointments as well. Yep, and in the bottom left there, we can, see appointment statuses by the scheduling provider. So we can see, they're arrived, bumped, and canceled and no-show appointments as well.
Yeah, and this gives us a little bit even greater insight. And one of the things that I look at with this is I can look at my providers who may have lower utilization and look at it and say, what's their third next availability? And if their third next availability is high, I have to wonder why. If their schedule's not being utilized, why can't we get them in? There's got to be some system restrictions that we're looking at that way that we need to clear out of the templates, because we should be able to fill those schedules. On the other side of things, I also see a lot of capacity here when I'm looking at my third next availables, because we've got a lot with low third next. And so if I, kind of filter in on those a little bit and then start looking at those appointment lags, the appointment lag being the difference between when the patient asks for the appointment and the date of the actual appointment, I can see I can get a lot of patients in within 8 days, but most of the appointments are being scheduled more than 7 to 14 days out. And so what's the disconnect there that we really want to dig in and try to better understand? If the system says we can get people in, why aren't we? And so this visualization really helps me as an executive in just a minute or two be able to go in, and sometimes good analytics really drives more questions than it answers. So there's a couple of other metrics that I like to look at too. These are the ones that I would consider maybe most difficult to get. But if you can, these can really give us a lot more insight into some inefficiencies in the way that maybe we're doing things. And that's looking at cycle times and maybe some technical things in the templates with frame sizes and slot durations and things like that.
Yeah, and I always find cycle times to, is an interesting visualization, right? So, with cycle times, we're trying to measure how patients are spending their time in the clinic. How much time are they spending in the waiting room? How much time are they spending in the exam room while they're waiting for the provider? Versus how much time are they actually spending with the provider themselves? And then from there, just analyzing how they all compare. So Scott, when you're looking at something like this, what are you noticing or what are you looking for?
So I see a couple of things, especially in that one right there on the right. I can look at Mike Allen and I can see he spends a lot of time with the patients. Now that can be a good thing, because from a patient satisfaction standpoint, they probably feel like he's answering all their questions, he's listening to their concerns, spending an appropriate amount of time, working with them. But it makes me wonder if he's maybe doing some things on the front end of that could be, better done by some physician's assistants or nurses or things like that would allow him some time in his schedule to maybe fit a few more patients in per hour. On the other side of things, I look at someone like Sheila Wilson, and if I look at the center graph where I can look at the actual durations and the scheduled durations, I can see there's kind of a disconnect between her slot durations and her appointment durations that are out there. And sometimes that happens. You may say that the template slots are set up for 20 minutes to see 3 patients an hour, but the appointment durations based upon the visit type are only 15-minute appointments. So really you could get 4 in per hour. When you look and you break that stuff down, again, it can get kind of technical, but that's a way to find capacity pretty quickly. If you start looking at, 1 additional appointment per hour per provider, that adds up pretty quickly. And so really just taking that additional insight that we can see can help us to find ways that we can get our patients in a little bit quicker.
Absolutely, absolutely. So, we showed a few different visualizations, but I always kind of think, why aren't more organizations doing these kinds of, high-level patient access visualizations? So let's take a second and talk about some of the common challenges. Oftentimes scheduling systems don't necessarily, correlate well with other systems easily, so it can create some difficulty lining up, necessary data. And this typically requires some kind of back-end data staging or an analyst to do those kinds of things. One of the biggest challenges I see is timeliness and accessibility of data, right? So, sometimes it's not easy to get the data. I often see organizations attempt to take on a patient access initiative. And they'll often have some initial success, but they'll experience a setback or a roadblock, and as a result, they put the project on the back burner, and oftentimes it never gets revisited. So these kinds of initiatives can be difficult. So, if you don't have experience doing these kinds of things, or if you're having, challenges getting to the data, it might be, worth hiring someone who has that kind of experience, or, reaching out to a company like PDS who's been doing these kinds of things, for several years at this point.
Yeah, I know that some of the frustrations that people have with patient access data is a lot of it has to be snapshotted at a particular point in time, and it can be difficult for people to take a look at things like that. And what's worse is sometimes it becomes that number becomes almost obsolete the minute that the snapshot is taken. And so what's really valuable is the trend over time and being able to continually do things like that. And like you said before, a lot of times scheduling data doesn't necessarily play well with other data like billing data or patient satisfaction data. And so sometimes the data staging on the back end has to be massaged a little bit so that you can really appropriately blend that data. And blending that data can be very, very important if you look at it, because productivity is or access impacts productivity as well. Yeah, I mean, a lot of times we talk to people who are doing patient access initiatives, and they said, well, our physicians can't get more productive, their schedules are completely full, or we can't add new patients, we don't have any time in the schedule, our providers are always running behind anyway. So the issue that we have is physicians don't seem to understand why they're not meeting their RVU goals or RVU targets, or why they're behind in their benchmarks, or worse, if they have RVU-based compensation and they're not hitting the targets that they want in order to get the compensation that they're looking for. Patient access sometimes plays a role in that and finding efficiencies that are out there. So some of the common metrics that I like to look at for productivity when we're doing that is lost appointment rates. And what those are no-show appointments and same-day cancellations. And if you have high levels of that, that's a very inefficient period, because that's time that we're usually not able to backfill, but it's time that was held in the schedule. So a lot of times that's just unproductive time that's out there. And if we have high levels of that, we probably need to find a way to address that. In addition to that, we need to start looking at, scheduling utilization, again, with the, in-office duration versus the templated duration, and understanding frame sizes and what's frozen and what's held. A lot of times frozen and held appointments, again, create bottlenecks from the standpoint of the schedulers who are trying to get patients in versus what the provider would allow in, because, hey, I've got time because I have these frozen and held appointments. That process issue creates a lot of inefficiencies and can be frustrating from both a scheduler standpoint, as well as a provider standpoint, as well as a patient standpoint.
Yeah, for sure, for sure. So why don't we take a look at a visualization that, going back to what I was mentioning earlier, blends different data sets and some of the metrics you just described, Scott. So, in this example, we're blending, RVU data here with, appointment statistics and other metrics here. We can even include things like coding data or, charge lag data if we want to.
Yeah, and this data blending type thing is where, it gets very useful, where we can come in and we can start looking at, I like to look at our patients or providers who have a high level of schedule utilization, maybe those that are even over 100%. And when I can filter in on those, I want to try to understand, they're up there, why are they still not meeting their RVU goals? who are my providers that are still below target on those RVU goals? And if they're at 100% of their schedule or more and not meeting their RVU goals, then I think there's some adjustments that need to be made, whether it's in the FTE standpoint or whether it's from a templating standpoint. We really need to understand why they're full but not hitting the productivity goals. In addition to that, we can look at providers that have maybe a high level of scheduling appointments but low number of appointments that are filled. And so a lot of this is really just trying to dig down and see. We can also look at things like coding and charge lag, which is provider efficiency on the billing side of things, which can help move them toward, those are big drivers of RVU productivity as well, with where the charges are getting held up and what's, being appropriately coded for what they're doing from a clinical fingerprint and an E&M standpoint.
Yeah, what's kind of neat about that is, the more you do those kinds of, that kind of work, you start to see some trends, right? But I think we could even take it a bit further and, share an example of a dashboard that, actually incorporates some trend indicators. So, as someone who looks at this, I like being able to differentiate, if you're doing a good job or a bad job at a quick glance, right? Are you above or below the target? Those green arrows make it really, really easy to see if trends are moving in the direction that, we desire as an organization.
Yeah, and I think the other thing that helps is looking at, benchmark level data, whether it's an internal target or goal or budget, or an external one. Adding some context to this is really important. So we are really big on trying to benchmark, and benchmarking can be difficult for a number of reasons, but there's different levels, and anytime you can benchmark at really any of these levels, that context is very appropriate. A lot of times when we work with clients and we start presenting some metrics to us, and they'll say, is that good or bad? Where do we want to be? And the first one I give them is, you want to be better than you were a year ago. You want to be better than you were a month ago, quarter ago, etc. You really want to, if you want to compare to yourself over periods of time, that's a trend benchmark that can be useful. In addition to that, you can look at internal benchmarks where you're comparing providers against just peers within their department or division or specialty or clinic, and looking at averages from that standpoint as well. You don't have to go outside to be able to add context to what each individual provider is doing compared to the average of their peers. External benchmarking is something that can really help organizations get to the next level, though, because they can say, here's where we want to be and here's where we expect to be. And so when we start looking at external benchmarks, the one consideration I would talk about is make sure you're taking care to understand how those calculations work and that they're the same that you're calculating, because there can be wide varieties of calculations for different metrics that are out.
Yeah, and when I think of benchmarking, Scott, I think it can be really interesting, because sometimes it's appropriate to have multiple benchmarks built into a dashboard. So in the example on the screen here, we're looking at a scheduling operations report that incorporates our clinic's actual performance up against our internal goal, but measuring all of that against an industry best target as well. And the way we have this lined up allows us to, for easy analysis, and it allows us to see how our activity stacks up against our goal, but also our benchmarks as well, right?
Yeah, and the thing I like about this is that we've incorporated an internal goal along with an industry benchmark, and this can help a couple of ways. One, there may be places where our organization is actually outperforming the industry, and we don't want to set less aggressive targets in order to regress to that. So we want to make sure we're continuing to be aggressive in our performance that way. But in addition to that, there may be places where we really want to understand for key metrics, where are we sitting from where we're supposed to be, and whether the goal is set by a target or whether it's set by an internal initiative that we're doing. We really want to understand our actual compared to the goal and what percentage we're looking at. So highlighting those in this dashboard can definitely be very helpful in giving just a quick glance of how we're doing. One of the other things that where benchmarking can really come into play is what we call our performance opportunity. And this incorporate some really higher level benchmarking, because we're looking at multiple metrics, but we're also doing kind of predictive level looks where we're saying what if. And what we're doing is we're trying to leverage the known. So we know what our annual collections are, we know what our total clinic visits are, we can easily calculate an average collection per visit, etc. And then we can start looking at other things that we know, number of sessions available, etc. And what we can do is we can start digging in and saying, what if? And we can start saying, what if every provider who was below the division average was performing at the division average number of clinic visits per session that's out there. So if we have some providers that are at 30 and some providers that are at 10, what would happen from a financial standpoint if we were able to move up those underperforming providers? And what that does is it attaches a financial benefit. And this financial benefit is something that can be a very compelling argument for change. It can be something that people look and say, if you were performing at this level, here's the benefit that it would bring about financially in terms of, number of additional visits, number of additional patients. And that's not even to say what would happen with regard to, quality or patient satisfaction as well. So this is definitely a way that a lot of organizations can go and really help kind of drive change within their organization, particularly with their highest outlying providers.
Yeah, and I really like that example, Scott, because to me it helps quantify the value of what a great visualization analytics can bring to an organization, right? So moving on a little bit, another area that I have been hearing quite a bit in, especially in the last couple of years, has been around the world of ACOs and value-based care. So in the world of value-based care, scheduling comes into play quite a bit too. So not only do ACOs have the same scheduling and demand challenges that we've shared throughout today's presentation, but they also have to proactively schedule their wellness visits, and this introduces some unique challenges as well.
Yeah, and actually value-based care is really kind of a where the rubber meets the road type thing, because when you really look at it, this is where reimbursement, patient access, quality, patient satisfaction all come into play and kind of merge together. And really, if we're trying to optimize all of those things, the best thing that we can do is actually be proactive in our scheduling, where we're reaching out to the patients instead of the other way around. So when we look at those things that really kind of drive, the key metrics that we'd be looking at that are going to help us with our quality outcomes, we really want to look at wellness visits. Wellness visits, particularly if we're on some sort of value-based reimbursement or HCC management program, we really want to make sure that we're getting patients in for wellness visits, because that's when all of our chronic conditions are coded, where they're all identified, and where we can start really understanding our patient populations from a risk standpoint. In addition to that, we can start looking at, are we doing a good job of managing our patients by keeping them out of the hospital? What's our outpatient services versus our inpatient services? And, can we start looking at patient engagement with our providers and start seeing, how are our referral trends for our specialists, or, for our primary care providers? Do we have a lot of patients out there who haven't been seen in some long period of time? How can we make sure we're getting those patients back in?
Yeah, when I think of that, when I think of this, I always think this is an area that it's so important to have a good tool set and a set of procedures, right? We can, in this example, we can easily come in and, right off the bat, identify who our highest risk patients are. And once we've done that, we can see which patients are, past due for any type of appointment. And taking a step further, we can see which of those patients are, on our future schedule versus, who we should be reaching out to. So ultimately, this is going to help us, utilize the tools to be proactive about scheduling wellness visits and, any follow-up care if needed.
Yeah, and this is a good one, because this is utilizing the tool basically to create a work list, like you're seeing here, that this is something where we know who our patients are that we really need to reach out to. But in addition to that, we can start looking at outlying providers as well and say, are there some providers that we could work with to be more proactive? where they may have a higher population of higher risk patients. And if there are, can we work with them to help them better manage these populations that are out there? So we talked a little bit about, how these three areas really kind of come together. We were talking about patient access, we're talking about productivity, we're talking about patient satisfaction, and how we really want to drive everything when we're looking at quality care and value-based care, where we have a bunch of metrics that we're managing from a patient access standpoint, from a productivity standpoint, from a patient sat standpoint. But when we really look at it, there's a lot more interaction between these different areas than we probably consider in the long run. So if we start looking at the intersections that are out there, we can find better efficiencies. And more importantly than that, when we start looking at these intersections, we can see what's most important. Where all three really truly meet is what our ultimate goal is or should be for our practice, which is patient productivity growth. That's going to help us financially. That's going to help us from a quality standpoint. It's going to help us from a patient experience standpoint. And it's definitely something that we want to make sure that we're managing to by being optimal in our patient satisfaction, in our revenue cycle, and in our interactions with our patients. Because when we have a patient-centric focus like this, everything else really kind of takes care of itself.
Yeah, absolutely. So at the end of the day, Scott, we spent a lot of time getting our data lined up, creating these awesome visualizations. But, how do we measure if we were successful with a patient access initiative? How do we gauge our success in this instance?
We see more patients. I mean, really,
that's the obvious answer.
Yeah, that's what we're looking for. If we're trying to get more patients in, we're trying to get them in quicker. And so if we start seeing those trends going in the right direction, then we know our initiatives have been successful. But really, we also want to make sure we're not putting a huge additional utilization challenges on our providers. We want to make sure that we're not burning them out and that they're satisfied as well, that our staffing ratios are where we expect them to be. But really, when you think about it, as someone who's done a lot of patient access initiatives, as someone who did a very, very high level important patient experience initiative, I had a quote from our old CEO that stuck with me all these years. And really what he said is, you know what, all of the things that we do, it doesn't really matter what we do. Patient care is not excellent unless the patient thinks it is. And so we have to make sure that we're managing our patient perceptions as well when we're looking at this and understanding what our patients are saying, whether we see it through our surveys or through the interactions that we have with our individual patients.
Once again, thank you to all our attendees. We hope you both enjoyed and learned something from today's webinar. Thanks again.
Thank you, everybody, for joining us today.